This lecture is the fourth in the series regarding aortic stenosis. With this lecture here, we'll understand how the continuity equation is applied to the assessment for stenotic lesions. We'll learn about the limitations that must be considered when working with the continuity equation. And then we'll cover principles for pleometry, a method for working out valve areas. The continuity principle is our grounding rule that we use in our evaluation. What goes in must come out between two areas of the heart, assuming that there is a closed circuit. Therefore, the flow in the LVOT must be equal to flow through the aortic valve in the absence of a membranous ventricular septal defect. As we can see here, stroke volume through the LVOT equals stroke volume through the aortic valve. Consider if there was a perimembranous ventricular septal defect. A cross-sectional area of the aortic valve calculation would be distorted. The stroke volume through the LVOT would be greater than that of the aortic valve. The aortic valve area would be larger than expected, leading to an underestimation of valve severity. Mathematically, the principle is demonstrated as below. We know stroke volume is equal to the cross-sectional area times velocity time integral, and we know that cross-section area can be further broken down into 0.785 times the diameter squared. So, having our assumption that the stroke volume through the LVOT equals the stroke volume through the aortic valve, the calculation gets expanded. The cross-sectional area of the aortic valve is what we want to do, calculate, so this gets moved onto the other side of the equation, and then we have our formula here. The maximum velocities of the LVOT and aortic valve may be used and substituted instead of the velocity time integral, but the VTI is definitely the preferred method. The diameter halved is the radius of the LVOT. To minimize the effect of the assumption that the LVOT size is uniform, it is important that when evaluating the aortic valve that its measurement is made mid-systole during flow. The VTI is obtained by placing pulse wave in the LVOT at the valve level and then moving the sample volume back towards the apex to minimize the effect of flow acceleration and remove valve clicks or leaflet motion. Using the machine measurement tool, we draw around the flow, thus capturing the entire range of velocities over a period of time. The velocity time integral of the aortic valve is obtained by placing continuous wave through the valve and obtaining alignment most parallel with the flow. This means investigation from multiple windows, such as apical, suprasternal, supraclavicular, and right parasternal. However, the location for the probe placement is not limited to these, such as a subcostal or left parasternal window may offer the best alignment. Finally, a good sonographer will always use the CW probe for their investigation. It is considered bad form to use the standard imaging probe alone, as the CW probe will always attain the same velocity, if not higher, due to its design and purpose. And here we have an example of a stenotic aortic valve taken from the parasternal long axis view. And to measure our left ventricular outflow tract diameter, we want to take the insertion point that comes in here with the right coronary cusp, and then assuming this is the non-coronary cusp, the insertion point here. So our true diameter is here to here. By placing the pulse wave in the left ventricular outflow tract, typically this is done from the apical 5 or apical long axis views. We can see our velocity time integrals that would be attained by doing a tracing along the border. Now it's important to note that when we're actually tracing the pulse wave flow for this particular measurement, we want to take the modal velocity, which is the inner brighter edge. We don't want the fuzzy stuff on the outside, the inner brighter edge. We want to capture the main movement of blood cells in that sample volume. We don't want to capture the maximum, we don't want to capture the minimum, we want to capture the main average. And this particular Doppler tracing we've taken from the apical window. It's a downward speaking one. And basically with this we want to trace the leading edge velocity, so the very much outer edge. We're not concerned about the number of blood cells that make the signal. We want to capture the blood cells that are moving at the highest velocity. And in this particular one here, we've got a upward profile. So this is being taken from a right parasternal window. Typically, we'll find that the right parasternal window offers the best approach to give us the best velocities. So it's definitely one that must be considered as part of the standard exam. Putting the continuity equation into practice, we have our example here. LVOD diameter of 20 millimeters, LVOT VTI of 12.3, and an aortic VTI obtained of 26.5. Throwing it all in, we come up with this. Remember, we need to halve the diameter to convert for a radius, and our aortic valve area is 1.5 centimeters squared. Coming down to our table down below, we know 1.5 sits in the order of getting close towards mild to moderate aortic stenosis. The stroke volume calculations used in the principle for conservation of mass are based on a simple hydraulic formula that assumes uniform flow is moving through a fixed cylindrical tube. As previously noted, there are instances when these assumptions do not always hold true. The diameter may not be measured correctly due to suboptimal imaging also. This may be due to significant calcification, annular rings, valve repairs or replacements. The incorrect determination of this value impacts the end result significantly. The incorrect timing in the cardiac cycle may also be taken. One of the above assumptions is the cross-sectional area is fixed. However, this may change through systole and diastole. The correct timing is mid-systole for the semilunar valves and early diastole for the atrioventricular valves. The VTI attained may not be accurate. The modal velocity and leading edge need to be applied and traced appropriately. And parallel alignment to the flow is required. The ultrasound being off angle will reduce the end result obtained. The placement of pulse wave sample volume, particularly for the LVOT, needs to be in the correct position. If the sample volume is too close to the valve, we collect flow acceleration, and we may also collect valve clicks. If we're too far away, then we're not actually measuring at the right sample place. Beat-to-beat variability needs to be minimized with averaging and appropriate tracings chosen. The stroke volumes through two locations may not be equal when there are intracardiac shunts. When there is a perimembranous ventricular septal defect, the stroke volume through the LVOT would be greater than what is through the aortic valve. This would lead to an overestimation of the aortic valve area. If the simplified equation is used with the substitution of the VTI with peak velocities, the user must be aware that the flows through the LVOT and aortic valve may not be simultaneous, and therefore accurately demonstrate the maximum velocity at one point in time. An additional problem may be encountered when using peak velocities for prosthetic valves, as there is a rapid pressure recovery of flow moving through the valve and localized high velocities. In doing so, this method may underestimate the actual valve area. Finally, we must consider that when there is poor cardiac output, that flow may not sufficiently open up the valve. In these instances, the valve area may overestimate the severity. Determining whether aortic valve stenosis is significant and warrants patient management is challenging when there is also severe LV systolic dysfunction. A patient may require a dobutamine infusion at low doses to stimulate an ionotropic response or increase contractility. When the patient does not have significant stenosis, the sonographer will observe a larger increase in the LVOT velocity over that through the aortic valve. A recalculation of the valve area will show an increase. In the presence of severe aortic stenosis, the VTI will increase proportionally for both, and thus not really affect the calculation for valve area. Pluminometry is an easy method that correlates well with invasively obtained areas when performed appropriately. It is important to note that this method is flow dependent in that the leaflets open less in the presence of significant LV systolic dysfunction and may not be a true reflection of the valve stenosis severity. Transesophageal echo is a superior modality due to its greater spatial resolution and fewer obstructions to attenuate the ultrasound beams, and can make it a little bit easier to do our telemetry measurements. Colour flow Doppler may also be used to assist in determining the valve area. It is important to note that colour pixels are larger than that of 2D image ones, so colour overlay should not be used to actually perform the trace itself. There is also significant difficulty in ensuring that the sonographer is actually at the leaflet tips and on face with the valve. Often a degree of tilt and or rotation are applied, and we obliquely cut the valve. Dense calcification reduces accuracy, as they may be artifactual representations, but also blooming associated bright areas on the screen from strong interface. The valve must also be measured when the valve is opening at its largest size, and this may be difficult to determine which frame that exactly is. And here we have an example of telemetry. So on the left here we can see we've traced around on the inside of the commissure lines to work out our valve area. But the example on the right, it'd be very difficult to know where our tracing actually needs to go. So in this instance, you'd find it actually difficult. You'd also be concerned that the annulus does look a little bit off kilter, so you'd think that the sonographer isn't typically on face with this particular valve. So in summary, the continuity equation is widely used for the assessment of stenotic valves due to its high reproducibility and both intra and inter-operative results. Learning the equation and with the application of a little algebra, a sonographer can manipulate the equation appropriately. The reference reagents for valvular issues are provided for the valves, and an area is often preferred to a peak or mean pressure gradient, as these are dependent on the LV driving them, such as poor ejection fractions lead to lower than expected gradients. Telemetry is a well-validated process that obtains results that correlate well with catheter work. However, care needs to be given by the sonographer to ensure the measuring is on face, on the correct frame, and actually at the leaflet tips.